Good morning. My name is Betty Reyes, and I will be presenting pain management and reassessment, the appropriate interventions for treatment. Pain is one of the most common patient problems that we have in healthcare today. It is considered the fifth vital sign and should be utilized as so when assessing the patient during nursing assessments with blood pressure and pulse, temperature, and respirations. It's very important that we stay on top of a patient's pain level. I mean, it is the patient's perception, but it's a priority for the patient and as well as for the practitioners in maintaining low pain levels. There are various classifications of pain. We have the acute, which is usually of short duration and usually reversible. Chronic is more of a persistent pain and on average has a duration of over 3 months. Nociceptive pain is a result of pain receptor stimulation, as in a broken foot or a laceration. Neuropathic pain is a result from nerve damage or neurological dysfunction. Inflammation is the stimulation of nociceptive processes by chemicals that are released during the inflammatory process. This is something in case like with a CHF patient who is having immense swelling in their extremities and that kind of pain because it's so inflamed, or from an infection, that kind of pain. Somatic is a nociceptive process activated in the deep tissues. Visceral is the nociceptive process is activated in the organs such as the liver or the bladder. And referred pain is a pain that is felt at a distance from the site of origin, as in if a patient falls on their knee and their lower leg is in pain, that is a referred pain. I'm sorry. The article analysis done was on treating acute patient in the opiate-dependent pain in the opiate-dependent patient. The author, Colleen Deaver, is an honors graduate who is now a certified clinical nurse specialist with over 5 years of diverse experience. Her literature review article discusses pain management, the control of it in the acute setting, and provides alternate ways of interventions and of relieving pain before actually dispensing an opiate to treat the pain. And the second article analysis consistency between opioid-related mortality trends derived from Poison Center and National Vital Statistics System. In the United States, the authors provided analysis of different areas, including objectives, methods, and conclusion. This analysis was data collected from 2006 to 2016 in the National Vital Statistics System and RADARS, the Research, Abuse, Diversion, and Addiction-Related Surveillance. This article provided a background on the devastating numbers of people that have lost their lives due to either opioid abuse or overuse of the opioids. In just this 10-year period, we lost 200,000 people from overdoses related to the prescribed opioids. Reimbursement has affected facilities, and prior to 2018, the age caps were determining whether a facility would get their full reimbursement depending on how they scored on their pain management section on the age caps, which is the Hospital Consumer Assessment of Healthcare Providers and Systems Survey. This survey was developed by the Centers for Medicare and Medicaid Services and the Agency for Healthcare Research and Quality. As stated before, up until the end of 2018, this pain score determined whether a facility was to reach their full reimbursement from these agencies. since determining that patients' pain is subjective and a personal thing for the patient, they could no longer use this to determine reimbursement status. It is still used in the survey to monitor and watch for trends, but it is no longer affecting how much a facility will gain in their reimbursements. The facility for mortality has a goal of 0.75%, and unfortunately our facility has been at 0.95% for the last 2 quarters. So with this, we have turned to starting a education program that will help to increase or actually decrease mortality and maintain our goal. The nursing quality nurses have updated and rewritten the pain policies having to do with the opioids to include specific guidelines and dosages based on evidence-based practice. The education has been presented to the physicians so that they understand that there has been a change and that there are new guidelines that need to be followed for dosages on opioids. Pharmacists have also been updated so that they are aware that when orders do come through for something that's not supposed to be utilized, they can refer back to the policy and have that discussion with the physician. The nursing staff is also being educated at this point so that they understand that not only do we have certain dosages and guidelines to follow for these medications, but also to empower them to speak to the physicians and stop the line when it comes time to administer the dosage. The nurses have also had another piece of this education, and it will be to basically teach them how to properly assess the patient for pain, utilizing tools that the system has, and documenting those assessments appropriately in the computer system. They are also being taught that there are other interventions that should be approached and utilized as well. Not all patients will be receptive to those, but to at least try and do that prior to just administering the medication. With that, there is also education that is going to be provided to the patients prior to administration of the opioids and also prior to discharge, so as to know the signs and symptoms of over sedation, so that they can also be empowered in their own care and know that just because the physician prescribes that medication for them does not necessarily mean that a lot of it is going to be good for them. So these education plans are occurring as we speak and are helping the staffs and the physicians to utilize their interventions, to document interventions and document dosages and assessments properly. For financially, the education is going to put a dent in the non-productive hours because it is education, and because we want to make sure that everyone across the board gets the same message. There's going to be a little bit of a spike in non-productive hours, and we are going to get pushback from physicians because they've had the other policies for so many years that sometimes it's hard to get them out of that train of thought. So providing the evidence-based practice and the evidence for safety, they should be on board with that as well. The entire staff and physicians being on board will help to project a lower mortality rate and provide patients with a better quality of care and allow the nurses to be able to speak and advocate for the patients when it comes to something that they know has been changed and taken care of. Yeah, that ends my presentation. Do we have any questions? Thank you.